reputed journals, course instructor faculty for ATLS, ACC, NELS, FCCS Obstetric, and CCLS and BCLS. She has more than 121 publications in index journal and several book chapters. And Dr. Uma will be talking about the equipments which is used for neuraxial anesthesia and nerve blocks. So I invite Dr. Uma for her talk.
A very good morning to all of you. My sincere regards and respects to Dr. M.D. Kaur ma'am and team APPEC for this golden opportunity. The topic of my lecture is equipment for central neuraxial and regional block. I shall be restricting myself to the equipment part only so as to save time and to make you understand that this equipment can be kept in any of the table vivas and also be asked as part of your viva examination. But the general requirements for any kind of regional block or central neuraxial block is the proper anesthesia setup with resuscitation equipment, airway cards, IV lines and fluids, emergency drugs including the anesthetic agents as well as the intralipid for local anesthetic toxicity, sterile sets and maintenance of complete asepsis and biomedical waste management, as well as adequate patient monitoring and taking a proper consent before the procedures. The entire paraphernalia and the array of needles available, nerve locators and ultrasound machine needs to be present before embarking on any kind of procedure. Now coming to the procedure per se, I would give a lot of importance to sterility and asepsis, especially in central neuraxial blocks, about which I will be talking initially. So both commercial and ready-made kind of sterile sets are available, but yes, you can also have your own indigenous CD sets and sterile sets for these procedures. Now, the most important aspect of central neuraxial blocks is the various types of needles which are used for giving these blocks. Most of these are either for spinal or epidural, and sometimes you also have a combined spinal epidural set or continuous spinal anesthesia. So, I'll be just giving you a brief overview of this. This is the blunted bevel 25 gauge needle. This is a long bevel 25 gauge needle. Can you appreciate the difference in the needle tips? I shall be coming to it in a little while. This is the ultrasound imaging needle. I'll be showing it to you at the end. Then you have the short bevel needle, and all these types of needles are designed to minimize the risk of PDPH and other complications over a period of time. Now coming to the spinal needles, this is the Sprott needle, this is the Whittaker needle, this is the Green needle, and this is the Quincke needle. Now the epidural needle, this is the Crawford needle, this is the most commonly used, the Toohey needle, and you have the Husted needle and the curved epidural 18 gauge needle, and this is the of course this is the spinal needle, the Whittaker 27 gauge. So these are basically the various types of needles which I will be discussing shortly, and this is just a diagram depicting the tips of the various needles which are used in central neuraxial block. Now coming to the needle tips. Now these needle tips, they are the main identification markers of the needles which are used. Now coming to this is the Quincke needle. Can you appreciate the beveled tip of the needle and the opening at the end of the needle? And this is the Quincke 18 gauge needle. This is the 16 gauge Toohey needle. Can you appreciate that this is slightly thicker and of course there is a bevel and this is curved. Now coming to this is a type of Yale needle. Then you have a 24 gauge Sprott needle and a 25 gauge Whittaker needle. So most of us are using these two types of needles for spinal, and then this is the pencil point needle and this is the cutting bevel needle. So these are the two main types of spinal needles which have evolved over a period of time. Earlier we used to use these cutting needles and there were a greater incidences of PDPH, and then these pencil point needles, as you can see that the point of these needles is like a pencil and hence they are called pencil point. Now coming to the spinal tips, now these will be asked in your examination, so you should be very thorough and clear about it. So the spinal needles are classified according to the needle tip as cutting tip or Quincke needles, which have a sharp cutting tip with hole at the end of the needle. Whittaker and Sprott needles both are pencil point needles. As you can see, they look like the point of a pencil and they have a closed tip, as well as this hole which is there on the side of the needle near the tip for injection of the exit of the drug. And the pencil point needles, they were designed to minimize the leak of CSF after dural puncture and reduce the chances of post-dural puncture headache. So coming to the close-up of these needles, again I'm stressing because this is what will be asked in your examination. This is the Quincke needle, this is the Whittaker needle, and this is the Sprott needle. So in 1951, Whittaker and colleagues, they developed this kind of pencil point needles to reduce the incidence of PDPH, which was seen with this Quincke needle earlier, and they basically used it to reduce the incidence, as I have explained previously. Now again, the spinal needles, they have three main parts: the hub, the cannula and the stellate. And the point of the cannula is beveled and has a sharp edge, and there are various gauges from 18 gauge to 30 gauge, and the length also varies from 3.5 to 4 inches, and it is color coded to identify the gauge. So as you can see, these are the various color codes which are used, and as I told you previously, the Dura cutting needles are the Quincke Babcock, this is the name, and the Pitkin needle. Pitkin needles we are not using, and the Dura separating needles, Whittaker and Sprott needles. The size is 16 to 18 gauge, but generally the ones which we are using is the 25 and the 26 gauge needle. So these are the most commonly used ones. The 25 is orange at the hub and 26 is brown at the hub. We also use 22 or 23 gauge needles depending upon requirement of the patient, and longer needles are available for obese patients. So again, coming to the Whittaker and the Quincke Babcock needles, this will be asked in your examination. To describe the Whittaker needle, you have to say that this is a pencil point needle with a small hub and pencil point type of bibble, completely rounded, and the opening is on the sides. It is non-cutting and solid, and a side opening is 2 mm proximal to the tip. And the Quincke Babcock needle, it is a medium length with sharp edges, cutting bevel, hub with lure lock connector and end injection, that is at the tip. And the green needle, this is again a spinal needle with a small hub, medium bevel, rounded, non-cutting edges and end injection, as you can see here. Then the Pitkin needle, you have a very small hub, short, sharp point bevel with cutting edges. And the Sprott needle, of course, this is one of the best spinal needles. They have a side injection port with a long opening. As you can see here, it is elliptical and it causes more vigorous flow of CSF. But there are chances of failed block if the distal part of the opening is in the subarachnoid space. So you need to understand the uses and problems with each kind of spinal needle. Historically, the beveled Quincke needle was used earlier, but then Hart and Whittaker, they introduced this pencil point to reduce the incidence of PDPH. And there is one more type of needle known as the A-Trocan needle, as I already told you. This has a cutting tip and a double bevel, which is intended to cut a small dural hole and then dilate it. But yes, this is associated with a very high incidence of PDPH. Now, as I told you that there can be a discussion on PDPH when we are discussing these spinal needles. So you need to know the risk factors. I will not be going into the details of this. These are all available in your various textbooks and articles. But yes, you must remember that spinal needles which are extremely thin increase the rate of failure because the backflow of CSF may be limited, and that itself can cause multiple dural punctures and unsuccessful punctures, and hence that too can become a cause of raised PDPH incidence. Now coming to continuous spinal anesthesia catheters, these have really come up in the recent past, especially in obstetric anesthesia. They have been a great boon, especially in cases of patchy epidural blocks which may occur because of various problems in the spine. And this is the set which is generally used by various companies. But before that, kindly focus on this diagram which says what you can can see here is that this is the catheter, and the catheter is threaded over the needle. So please remember that generally these catheters are usually they are put in over the needle, and the stillet is removed to see the feedback, and the feedback is nothing but CSF. And then the catheter is threaded over the needle into the subarachnoid space. And there are various types of catheters. These are strictly regulated by the FDA because there have been earlier incidences of cauda equina syndrome, which is a complication of continuous spinal, which you must remember, and complete asepsis and proper technicalities need to be followed. Now coming to the needle per se, there are various parts of the needle. This is the needle hub, and this is the flexible cannula hub and the interlocking hub, and then you have the flexible cannula over needle, right? So needle is inside and the cannula is outside, and then the needle is generally 27 gauge and the cannula is generally 26 gauge. So this is a very effective technique, and you also have things to fix the continuous spinal. Now coming to the procedure as such, I would not be going into the details of the procedure, but this is how it is generally done. An 18 gauge 2E peel away epidural sheath is introduced, then a 27 gauge spinal needle is introduced through this epidural sheath, and a 23 gauge flexible cannula is threaded over the spinal needle, and then the peel away epidural sheath is removed, and then the cannula is advanced over the spinal needle, and then the wire wig, this is actually a trademark of this particular company, this is attached to the cannula using a lure lock connection, and the proximal cap is removed and the kit is fixed. So this, you need to understand that complete asepsis and full technical details have to be followed. Epidural, coming to epidural needles, the most important one is the 2E needle with a lure lock connector and the tip curved, as you can see here. This is for directing the catheter into the epidural space properly. The bevel is medium length and it has a cutting edge. Hence, you must remember that if there is any inadvertent dural puncture because of the epidural needle, then there are higher incidences of PDPH. The bevel of the pointer is known as the Huber point. So this can be asked in your examination. Please remember how it looks and how you have to answer. Now the 2E needle was actually developed by Ralph L. Huber. He was a dentist. But it is known as Edward Boyce 2E, who was the first US anesthesiologist who popularized and used it in 1945. Now the Huber tip is available in both detachable and fixed wings, and 17 or 18 gauge for epidural catheter insertion use, and 20 gauge and 22 gauge for single shot epidural use. And the angle of the blade tip is designed to enhance the tactile response during insertion and ensure the smooth insertion of the epidural catheter. These are the various types of epidural needles which are available, but we are generally using the 2E needle. So you just need to remember the names, and the most important one, that is the 2E needle. Now the equipment, as I previously told you, complete sterility needs to be maintained. But apart from the epidural needle, there are other things which are available in the epidural kit, which is basically the loss of resistance syringe, the epidural catheter, and the fixation devices and the filter. So a higher gauge needle equates to a thinner epidural needle. This you must remember. That means that an 18 gauge needle is thinner than a 16 gauge epidural needle. So both these are the two commonly used gauges in adults. So that is what you need to understand. So this is a close-up photo of the 2E needle with the gradations and the gradations in the epidural catheter as well. So these gradations are also important, that up to what length you need to fix, keep the epidural catheter into the space, and at what length you need to keep it in the skin. And these are the gradations, and this is marked on a pencil. You can see that there are 1 centimeter marks here, black and silver, and this is the needle hub, and this you have the stillet which is detachable. So now the epidural needle, each centimeter of the epidural needle is marked with alternate black and silver colors, and the loss of resistance is basically because of a pressure difference when the epidural space enters the correct location, that is the epidural space. And the unique feature of this Tuohy needle is that at the end it has a directional tip to allow the epidural catheter to exit the needle tip and aid in placement of the catheter in space. The needle also contains a stellate which remains in the needle when inserted into skin, and this stellate, what is the use of the stellate? This prevents a skin plug from blocking the needle before entering the space. And this advantage is that they have wings for better placement and grip. And epidural needles, they are designed, as I told you, with a curved tip to help prevent puncture of the dura. So that is the reason why we have a curved tip. And in case of inadvertent dural perforation, the incidence of headache can be lowered by identifying the epidural space with the bevel needle oriented parallel to the longitudinal dural fibers, which limits the size of subsequent dural tear. Now this is a close-up picture of the loss of resistance syringes. One is the lure slip and the other is the lure lock. As you can see that there are serrations, rounded serrations here, which are used for locking the syringe to the needle, the epidural needle, then looking for the loss of resistance. So this can also be kept in your exam. So this I have already told you, so I will not be going into the details, they are already discussed. These epidural catheters, they are radio opaque. As you can see, there are two types of epidural catheters which are used. One catheter has a single orifice and the other one, it has multiple orifices on the side. Now this is the epidural needle, this is the loss of resistance syringe, this is the epidural catheter. It has gradations on it, as you can see, 20, 15, 10 and 5, and this is just 1 centimeter gradations, the black ones, as you can see here. And this is the stabilizer or the connector to the needle. This is basically fixed on the epidural needle and this catheter is threaded inside. And this is the filter, this is a hydrophobic filter, and this is the connector, and this is the stopper. So all these you need to identify on your examination. Now these are all for historical purposes, the Lutz epidural needle and the other epidural needles like Crawford, Wagner and Cheng needle. Again, a closer view of these. They may or may not come with a wing or curved tip, or in this Tuohy flowers needle, which was modified by Flowers, the Tuohy needle, the stellate comes out of the bevel opening, and this is called the Tuohy flowers needle. All these were developed over a period of time, especially when in relation to obstetric anesthesia. Now coming to the combined spinal epidural kit or the needle or the technique, there are basically two types of technique, needle through needle technique and the separate needle technique. So the needle through needle technique is basically there is one epidural needle which is outside and one spinal needle which is inside. And first the epidural space is identified and the spinal needle is inserted inside or through the epidural needle, and this punctures the dura, and then it is fixed and then the drug is injected into the CSF. Now coming to the separate needle technique or the separate space, or maybe in the same space, the separate needle technique. This is the spinal and the epidural needles injected, inserted separately. So the disadvantages and advantages, I think I won't be going into the details, but yes, I would definitely tell you about the spinal needle in the CSE. This is important because the ideal length of the spinal needle protrusion beyond the epidural in a CSE kit is 12 millimeters, and the conventional spinal needle in CSE kit is difficult to handle and stabilize during the spinal medication, and hence a special lock was developed over a period of time to prevent the displacement of the spinal needle during fixation of the drug, aspiration of CSF and drug injection, so that the needle is not, the spinal needle is not pushed deeper, which can actually cause nerve damage or maybe even failed spinal. The spinal needles with adjustable locking device were introduced, and these lockable extensions, they provide safe and stable conditions during placement. Generally, the spinal needle is a pencil point needle, 27 gauge, and this extends around, as I told you, 1.2 centimeters past the tip of the epidural needle for intrathecal injection. Now coming to the diagram, as you can see, this is the 2He epidural needle with a curved tip, and this is the spinal needle coming out. As you can see here, this is the epidural needle is penetrating the ligamentum flavum, and the spinal needle is penetrating the dura into the subarachnoid space for the CSE. Inadvertent epidural catheter protrusion to the dura hole made by the spinal needle can be a complication, and in the needle through needle technique, so that we need to understand and remember. This is a diagram of the needle through needle technique, wherein the Whittaker pencil point needle, it deflects by 10 degrees from the tip of the epidural needle and enters the dura. And there is one more CSE kit which I'll just demonstrate in the next slide, that is the elder needle technique, where there are two holes. The double hole pencil point spinal needle, it exits on the side, the spine known as the spinal conduit of the elder needle, in a straight direction. As you can see, this is in a upward deflection of 10 degrees, and this is in a straight direction and parallel to the epidural tip. So these are two varieties. This, as I told you, is the Eldor needle. This is only for your historical purposes. You just need to know what is the Eldor needle. Now, this one advantage of the Eldor needle is that the spinal conduit which is there, this serves as a brake at the ligamentum flavum for an inadvertent insertion into the spinal space of the epidural needle. So the chances of PDPH can be less if proper technicalities are followed, but this is quite an old needle and hardly used nowadays. Now one more needle which can be asked, which may be asked in your examination, is a double lumen dual orifice CSE needle, where there are two orifices, one for epidural and one for spinal. So there are two separate lumens for the catheter and the spinal needle. Now coming to regional blocks or needles or equipment for regional blocks, you must understand that any kind of regional block has to be done with patient safety being the foremost important aspect. So you need to have a proper regional anesthesia cart with all the needles, the emergency drugs, the fixation material, the IV fluids, the drugs, the local anesthetics, the adjuvants, and everything stocked up and checked on a daily basis. So all these things are very important. And one more is the checklist. Now this checklist you can use, or you can use your own indigenous checklist to make sure that you don't miss out on any aspect before taking up the patient for regional anesthesia. Now nowadays, with the advent of ultrasound guided regional blocks, you can also be asked about the ultrasound nerve block needle, which are actually echogenic needles. Why? Because they reflect the ultrasound beams which fall on them and make it very prominent. The normal needles may not be visible through the ultrasound machine. So the special types of echogenic needles were developed, and they have various mechanisms for reflecting the ultrasound beams, like trapping of micro air bubbles, grooves near the needle tip. These are easily visible in these needle tips, and they are their identification marks. And echogenic dots made by cornerstone reflectors at the distal end, they also help in identification. Now the enhanced echogenicity of these needles, they reduce the visualization time and enhance our ultrasound guided block experience, as well as improve patient safety and outcome. An echogenic needle with or without ultrasound beam steering is better visualized compared to a non-echogenic needle at an angle of 60 to 70 degrees. So mostly these needles are 22 gauge insulated needles, because you can also connect them to a nerve locator, and they are most commonly used. You must remember that the smaller gauge, the smaller size these gauge needles, they lack rigidity and they bend more easily, especially when you are going deeper for deeper nerve blocks, and hence there is a risk of the tip being inserted intrafascicularly within the nerve, and this increases the resistance on injection, and hence a longer time for blood aspiration if the needle tip becomes intravascular. At the same time, if you use a larger gauge needle, there is less of bending. Of course, that is advantageous, but the disadvantage is greater chance of tissue injury or hematoma, especially if there is a vessel lying underneath. Now, this is the diagram depicting the echogenic ultrasound needle. As you can see that there are holes and there are markings, and this is centimeter markings which can be used to monitor the depth of penetration, and the cornerstone reflectors are used for visualization under ultrasound. And there are basically two types of needles, the short and the long beveled needles, which are marked in the hope of better visualization. Equipment for regional block, as I told you, it is important not to dismiss the value of nerve stimulator, especially with the use of ultrasound, and hence you need to monitor the injection pressure to minimize the potential for nerve injury with the needles, and hence you must use a combination of monitors to minimize the risk of intraneural, intrafascicular injection and needle nerve trauma. Opening injection pressure should be kept below 15 psi, that is what is recommended, and there are various monitors which are available for them. You may or may not be asked about this in the exam, so I just thought I'll just make a passing mention. You must remember that a sudden change in impedance when you are using a nerve locator may indicate that the nerve is, or the needle is entering the tissue other than what is intended. So you have to be careful. Now there are various inline pressure monitoring devices which are available for nerve blocks, and they can measure the injection pressure, and that is what is important for us to monitor. So it should be kept below 15 psi. And there is another monitor which is known as compressed air injection technique, or CAIT technique. This is basically to prevent high injection pressures, because up to 50% compression of the air volume in the syringe with the local anesthetic corresponds to an injection pressure of 760 mmHg, which is quite high, and so we need to be careful about this. Now, one advantage of this catheter through needle assemblies which are used for continuous contiplex needles for peripheral nerve blocks is that the gap left between the skin and the catheter on the removal of the needle is there, but on withdrawal of the needle in the catheter over needle assembly technique does not affect the snug fit of the catheter, and this is because the needle is housed inside the catheter. So nowadays contiplex needles are basically coming with the catheter is there inside the needle is there inside the catheter, so that there is a snug fit for preventing displacement. So this is what is depicted here, right? So these are contiplex continuous catheter devices which are used for continuous regional blocks. Now coming to a quick overview of the peripheral nerve stimulators. I would not be going into the details because that is a complete topic in itself. So as you can see, this is the multi-stim sensor monitor. There are various brands which are available. We need to select four things. One is the stimulus amplitude, second is the pulse width in milliseconds, the frequency in hertz, and the impedance. And these are the surface nerve mapping probes for percutaneous electrode guidance. This can be used for superficial blocks, and they are very, very useful when using with the nerve locators. So this is the pulse width for various applications during peripheral nerve blocks. Most likely the pulse width which is used for motor peripheral nerve block is 0.1 milliseconds with a threshold range. You need to avoid less than 0.3. right? And these are other types of nerve locators which are used for adjusting the output, nerve output. There are various ones which are available. Now this is a portable ultrasound machine. One must remember that selection of nerve block monitoring equipment including devices to measure the current perception threshold, monofilaments and alcohol swabs for sensory perception, infrared scanning device and force transducers with wireless data collection capability is what is recommended for a safe technique. So now I am coming to the end of my presentation. I would really like to thank the organizers, especially Dr. MD Kaur ma'am, Dr. Neerja ma'am and the team of APPEC and my hospital colleagues and friends at Dr. Ram Manohar Lohia Hospital for this wonderful opportunity and giving me a chance to present about equipment on regional and central neuraxial block. Thank you very much. But before I end, I would like to show a few of the things, the needles which are used for regional block. I hope you are able to see the needle. This is the 25 gauge pencil point spinal needle. As you can see, it is orange in color, the needle hub. That is an identification color code. And this is the 26 gauge, again pencil point spinal needle. These two needles are the most commonly used. And since I didn't want to break the sterility of the needle and waste it, this is the ultrasound needle with the connected device and the lure lock, and they have this extension tubing also for injection of the drug. Now coming to the epidural kit, this is the epidural mini pack which has the epidural needle in it, the filter, this is the hydrophobic filter, this is the connector, and this is the loss of resistance syringe. This is the fixation device, and you have this for fixation at the back of the patient. So this is the epidural set. Now coming to the combined spinal epidural set, this is also very important. This is the loss of resistance syringe. This is the hydrophobic filter, and you have two needles here. One is the epidural needle and another one is the spinal needle. And you have this connector filter, and the filter is here, and this is the fixation device, which is very good, and it can be kept on the shoulder of the patient. And the catheter is also there, the catheter with the markings. So thank you very much, and thank you, and Jai Hind.
Thank you, Dr. Uma. You have really covered a lot of topics, which is very important for the residents to know. And in a very short time, very concisely, you have covered all the things. And
thank you, sir. Thank you.
It doesn't seem to be any questions.
So there is one question that is there in the query panel. If she can, ma'am can explain the dural puncture epidural technique, if she can re-explain it. So.
Yes, actually because of paucity of time, I couldn't cover a lot of topics. So one of this was dural puncture epidural technique. This is actually a fairly recent addition to the armamentarium of central neuraxial block. Here, basically what we are trying to do is we are trying to puncture the dura with a spinal needle in a proper CSE technique, but no drug is given into the subarachnoid space. Now, this technique was devised to limit the side effects associated with CSE technique, because CSE generally, when we use it for laboring patients, for obstetric patients, what happens is that it results in pruritus because of opioids, and it can also result in various side effects like severe hypotension and fetal bradycardia, which is very frequently seen when we use for obstetric anesthesia. So what we are trying to do is we are just puncturing the subarachnoid space with the spinal needle and not injecting, and giving the epidural injection just like a usual laboring epidural analgesia. So that causes effect of CSE without the side effects. For example, it causes the proper graded epidural effects, and it does not cause the side effects. So there are several studies which are being done nowadays to assess the efficacy as well as the advantages of this technique. But yes, we need more randomized controlled trials to establish its importance and assert its effectiveness.
Okay. Any other queries in the? There doesn't seem to be any other queries.
No, sir, there are no other queries.
Dr. Uma, one question from my side to you.
Yes, sir.
Why are these pencil tip needles less prone for PDPH? And they cause less incidences of PDPH. What
yes,
is the
sir.
theory behind it?
Yes, sir. Actually, there are two theories. One is that they actually cause a greater amount of inflammation in the CSF, in the dural membrane, which leads to earlier closure of the dural tear. Any needle, any spinal needle is going to cause some amount of dural tear, whether it is a pencil point or a bevel needle. In this type of needle, the inflammatory response is greater, so the sealing of that tear is going to be faster, and hence the incidence is less. The second theory, which is more obvious, is that the hole which is created by the pencil point is less, and that leads to earlier closure of the defect, whatever it is. So both these theories are complementary with each other, and that is the reason why they cause less of PDPH incidence, the pencil point tips.
Very nicely explained, because this is the usual question that is usually asked to the why is there in decreased incidence. Any other questions, or we can go back to the organizers?
Sir, there are no other questions.
Thank you, sir. Thank you, MD Kaur ma'am. Thank you, Dr. Namita. Thank you, Dr. Nitin. Extremely grateful to the organizers of Team APPEC. They are doing a wonderful job. And thank you, sir, for your guidance. It has been a real pleasure to be able to gain knowledge from you. I'm extremely grateful, sir.
Thank you. Thank you,
And
Dr. Uma.
Thank you, sir.
And thank you, Dr. Kaur and the team
Thank you.
Yes.
for inviting me.
Thank you, ma'am. Thank you.
Thank you.
We'll move on to the quiz session. The question is, physiological anemia is associated with all except A, increase in plasma volume, 50%, B, increase in RBC volume around 40%, dilutional anemia, and abnormal coagulation profile. Kindly answer in the chat box. Question 2, which of the following is pencil point spinal needle? A, Pitkin needle, B, Quincke needle, C, Sprouted needle, and D, green needle. Now moving on to the next session, most awaited session of long case presentation, which is full-term pregnant patient having pregnancy-induced hypertension posted for elective LSCS. The external examiner for this case is a very renowned and esteemed faculty, Dr. Kirtinath Saxena. Madam is Director, Professor, and Head of Department of Anesthesia and Intensive Care of Maulana Azad Medical College. And Madam has authored more than 100 papers and 13 book chapters. She is Editor-in-Chief of Journal of Indian College of Anesthesiologists, as well as she is on editorial board of 5 more journals. Madam is a rater for McMaster Online Rating Evidence System, which is offered by McMaster University, Canada. And she is also expert on anesthetic, resuscitation, and allied equipment, as well as expert in UPSC Commission, Government of India, and member of Education Committee of Indian College of Anesthesiologists. Madam is also expert in National Board of Education, as well as member of NHA Medical Cell of Ayushman Bharat. Her area of interest are obstetric anesthesia, pediatric anesthesia, difficult airway, regional anesthesia, and non-invasive pain therapies. I welcome you, ma'am. The moderator for the